Hey guys, welcome back to HEMSI Punch. This is Jordan. Today we're going to be talking about synchronized cardioversion in unstable patients and unstable tachycardia. So it's important to realize what unstable is fairly quickly so we can do those interventions. Our unstable, recognizable things right off the bat are going to be the profound hypotension, recurrent syncope, unresponsiveness. So before we get into the specifics, we're going to show you how it's done. So when you have your patient on the monitor and you have your patient's pads on, and that'll be anteriorly and posteriorly, we're going to make sure that we see the rhythm, and the first thing we're going to do with a pulse, we're going to verify they have a pulse, and then we're going to hit sync. So after we've hit the sync button, we want to make sure that we are truly synchronized with this patient's rhythm by the indication arrow at the top of every QRS. Alright, it's important to know that once we sync it, we do have to select our energy. So for our SVT patients, we'll start at 100 joules. For anything else, we will go at 360. This is indicating VTAC. Typically, your monitor will start at 360, but as of right now, it's starting at 100 because we've been using this one. So we need to go to 360. Once you hit that, you also need to verify that you still have the synchronized indicator at every QRS. You can then hit the charge button. Clear your patient and hit your energy button. There you go. After that, you'll notice that the synchronization has dumped. After every synchronized cardioversion, you will need to resync with the patient's QRS. So both SVT and VTAC are generally characterized by the absence of discernible P waves, and it's normally greater than 150, but it's important to note that certain patients may be a little slower than that. Not every tachycardic patient is going to be in SVT or in VTAC. Some of these patients are going to be in a compensatory rate. We need to do a full assessment of these patients and make sure that we are doing all of the questioning beforehand and looking at the total patient rather than just the monitor. We need to be looking at if they have any kind of like hypoxia, infection, hypovolemia, or other things that can cause their heart rate to go super high. It's also important to know what the maximum heart rate is. So that's going to be 220 minus the patient's age. So that's going to look different from an adult to a child. For someone who is 30 years old, the maximum heart rate is going to be 190. For someone who is 70 years old, the maximum heart rate is going to be 150. It's important to do this because we do not need to be lowering the heart rate of these individuals that are in a compensatory state. When we have these patients, we need to make sure, especially if they're unstable, that we're not taking time to start IVs and to sedate them. The most important thing is going to be getting their heart back into rhythm. Secondly, when we're talking about torsades specifically, like polymorphic VTAC, that it may not synchronize on the monitor, and just know that. In that case, you would not be using synchronized cardioversion. If they are unstable, you would be defibrillating these patients at 360. For pediatric patients, it's going to be 4 joules per kilogram, and for pediatric and adult patients, if you need to repeat for synchronized cardioversion, it can be done every 2 minutes. Always contact medical control for any questions that you may have. They'll be happy to look at any rhythm that you have and discuss it with you further. Thanks for watching this HEMSI Punch. We'll see you next week.